Good afternoon, Dr. Dean.
Hi.
Could you tell me where you went to medical school?
I went to Tufts University School of Medicine. Graduated in 1963.
Okay. And what did you choose as your specialty?
I was a hematologist, but once I came to Worcester, I filled a void, a vacuum. There was no one doing medical oncology, and I had some basic training in a related field, and I became a medical oncologist as well as a hematologist.
Is there anything else that got you into oncology? Anything else that made you choose that field?
Basically, I joined a group, the Fallon Clinic, and there was a need for somebody skilled in that particular discipline, and I filled that void.
And what got you into medicine in the first place? What made you choose medicine as a field?
Well, it's sort of hard to probably pinpoint a specific reason. There was a series of reasons. It certainly met a feeling of social responsibility, and it was a well-respected profession, and it's considered a noble profession by one of my colleagues, Leonard Moss, and I think it really is. So it was a combination. It was intellectually stimulating, challenging, and the opportunity to do some social good, and to be to make perhaps a difference in some people's lives.
Was there any family influence on your decision?
Not really. My parents only wanted me to be an educated person, and didn't really put any pressure. I'm the first member of my family to go into medicine, so there wasn't any dynasty type of calling. There are families in Worcester where the physicians are second and third generation physicians. I was the first in my family.
So do you want to describe your days in med school or your days as an intern or resident? Maybe
Well,
share some
just
stories.
just talking about it today with one of my colleagues, they were a wonderful time in one's life, the internship years. It was a real golden age of medicine in the sense that I had wonderful training programs at Boston City Hospital, Bellevue Hospital, and Cleveland Metropolitan General, and we had wonderful patient population. We saw diseases in their full flavor, advanced disease. There was a tremendous spirit of teaching that went on. We were given a lot of independence. We had a lot of responsibility. It was a lot of fun. It really was a very enjoyable period of my life. The pathology that one could see at a city hospital was limitless, and the esprit de corps and the camaraderie. It was just a very wonderful time in a young physician's training.
That's great.
Mm.
What year did you start practicing here in Worcester?
In 1968.
Okay.
The height of the Vietnamese War, which is one of the reasons I came to Worcester. I had finished my training at Boston City Hospital. I had been the chief resident, and I was in the reserves, and it was the height of the Vietnamese War, and we felt the reserves were going to be activated, and I was just looking for a place to perhaps spend a year and then seek a permanent position. And one of my colleagues who was finishing his training at Boston City knew of this clinic in Worcester that was looking for a hematologist. It was called the Fallon Clinic, and there were 9 doctors practicing here, and I came here and I interviewed with them, and I liked the people here. I liked what they were trying to accomplish, and what I thought was going to be a year or two experience, and turned into a 31-year voyage with this group. And it was a voyage because when I left, we were almost 300 physicians, so from 9 to 300 physicians. I was the 10th one here.
So describe a typical day when you started practicing medicine here.
Well, in the early period of my practice, we really had heavy inpatient practice. We had a lot of patients in the hospital, so it was not unusual to have 10 or 15 patients in the hospital, and to make hospital rounds for 2 or 3 hours in the morning and then come to the office in the afternoon. The hospital was teeming with doctors because the hospitals were busy. Most of them had many more beds than they have right now. In fact, there were 6 hospitals in Worcester and several in the periphery, where we have now just really 2 hospitals. And St. Vincent's had close to 500 beds, where probably now its descendant, the Worcester Medical Center, has probably around just a little over 200 beds. And so much of our practice involved the diagnostic workup, which took place in an inpatient setting. And patients who we now treat as an outpatient with advanced cancer, with chemotherapy, most of this was all done in the hospital setting. So that the hospital was probably a good component of the day. And then we came into our offices and practiced for another 4 to 6 to 8 hours. So a day would probably start around 7 or 7:30 in the morning at the hospital. Rounds were probably close to 11 or 12 o'clock, and then we would be seeing patients in the office till 6 p.m.
Did you ever use a telephone to talk with patients?
All the time. Yeah, there's a lot of telephone conversations with, and I think telephones probably the fact that most people or all people had access to telephones eliminated the need for a lot of house calls, because now people could communicate. They could describe what was wrong. You could tell whether they needed to be seen that day. Then they would come into your office where you had the facilities, you had the laboratory support. You could do a better examination, or if they sounded really sick, you knew they needed to go up to the emergency room or even be admitted, because you knew your patients. So telephone triage, which is an important method even today, was certainly a major way we practiced, returning calls to patients and having patients having access to their own physicians.
Did you ever have the chance to make a house call?
Oh, I made house calls. I made house calls. Many of the house calls were done more in terms of not necessarily for what you could do for patients, but it was part of the art of medicine, feeling attached to patients who were unable to come into the office, who you needed to assess what their status was, sometimes just to make a social call to a long-term patient who you really felt a commitment toward, and you wanted to maybe demonstrate your solidarity and commitment to them. And so I did make house calls in the earlier days. They became fewer as my practice matured. Your patients, when you go into practice, as you stay in practice, your patients age along with you, and so many of my patients that I first encountered when I went into practice stayed with me for the entire 30 years, and even though they may have had a malignancy, if they were cured, I became their primary care physician. So even though I was an oncologist, I did a lot of primary care, most of whom were former patients of mine who had had successful treatment of their cancer.
So when you consider your hours in the midst of your practice long, from 7 to 6, consider those long hours?
I consider them, sure, they were long hours, but that's certainly my predecessors were on call 7 days a week, 24 hours a day, and in a group practice we had good coverage. We had a weekend rotation, but the weekends you were busy. You covered several other doctors. You saw a lot of patients in the hospital, but then you had weekends off. So probably the coverage involved 1 weekend a month or 1 weekend every 6 weeks. We considered that very good. In the beginning, perhaps we were on every 3rd weekend. And I never minded taking my own night call because I knew my patients, and I didn't mind, and the patients were very respectful. When a patient called at early in the morning or wee hours of the evening, they were almost always legitimate. Your patients felt a measure, they weren't going to bother you with trivial things. So I didn't, and I knew my patients, and I preferred to take my own call during the weekdays. But I had, in a group practice, we had good coverage, and if I had to be away at a meeting or for vacation or time away, there was always good coverage by my colleagues.
So what do you think it was like for your family to have a physician in the household with you working so much during the week?
Well, I'd like to think I was a good husband and a good father. You'd have to check with my children, but we were a very close family, and I worked hard, but my family was very important to me too, and I made sure that I didn't neglect them. And that was one of the reasons why a group practice was a very nice way to begin one's practice, because there was good coverage, and there was legitimate time away from the practice where your patients were covered by very competent physicians, and who we would sign out to, and so that I was able to combine both what I thought was a successful practice with also a decent family life. Being a physician is not an easy job, and it's not a 9-to-5 job, and you make that commitment, and that's one of the sacrifices you sometimes have to make, but it was well worth it.
Did you get any vacations?
Sure. Again, the group practice, the quality of life was quite good, and I went away to medical meetings to maintain my expertise, and always knew that my patients were cared for and by competent physicians who had access to my records, and there was good continuity of care, and we always took nice summer vacations, and we did a lot of nice things as a family.
Do you have a favorite memory from when you practiced?
There are so many favorite memories. It would be hard to pinpoint. Being a physician is a privilege. People put their trust and their lives in your hands. So it's both tremendously gratifying. It's a big responsibility, but and patients become very attached to their physicians. There's a lot of loyalty. There's a lot of respect, and you become friends with your patients. So I have so many pleasant memories. I can't really find one that at this point that I would want to single out from any of a number of them. Yeah.
How about a least favorite memory?
Well, in the early days, coming into Worcester, having been well trained, I believed, finishing up my chief residency at Boston City Hospital, having completed a hematology fellowship, and joining what I thought was a very exciting medical group in Worcester, looking forward to practice. The first year, when it became time to join a medical staff at St. Vincent's, my colleague and myself, who came the same year, both of us were denied attending privileges at St. Vincent's because the other doctors in the community were very fearful that the Fallon Clinic was going to get too big and too strong, and they were fearful of group practice. And most of them were solo practitioners. And so thinking my credentials were impeccable and not having any realization of the politics of medicine, I found myself not appointed to the staff of St. Vincent's. And I was my colleague who came the same time with me to the Fallon Clinic, Dr. Podbielski, he and I were the only physicians ever appointed to the staff of St. Vincent's by the Bishop of Worcester. And so that was probably a very unpleasant experience, having felt that rejection. Many of these doctors who voted against our appointment became my friends in the community, but at the time they were dead set against seeing the Fallon Clinic grow, and that was a side of medicine that was not very pleasant, but yet it was a reality.
So what were the most typical illnesses that you dealt with?
Well, as a hematologist, I saw lots of patients referred to me who were anemic, who required bone marrow examinations. Unfortunately, we had a fair number of people with leukemias that I had to treat, and I also, as an oncologist, the big four: colon cancer, lung cancer, breast cancer, prostate cancer. Those are the types of patients that were commonly seen and treated.
And did the illnesses that you saw change at all over subsequent decades?
Well, the advances in medicine are tremendous, and the prospects of what lies ahead over the next 5 to 10 years is even more tremendous. I think that we're going to see major changes in how we treat cancer, and we're going to see a whole different approach in terms of instead of using chemotherapy with poisons mainly, we're going to see the introduction of a whole new category of drugs that affect the receptors on cancer cells, that block the signals in cancer cells, and we're already beginning to see the introduction of these kinds of drugs in chronic myelogenous leukemia, in breast cancer, and I think we're going to see an explosion of new therapeutic options that will lead to much better prognosis in the next 5 to 10 years. I'm very optimistic about the improvements in this particular field, and in many fields in medicine. The ability to diagnose ailments is advanced tremendously in the last decade or two with the introduction of radiological techniques with CAT scans and MRIs. We used to have to do exploratory laparotomies and autopsies to determine what was wrong with them. We now know, we may not be able to cure them all, but we know without having to do exploratory laparotomies, without having to do autopsies, we know pretty much what has happened to a patient. The ability of radiology to do procedures that were very complicated and dangerous in a much simpler way to spare patients a major surgery, to be able to remove a gallbladder the same day without having a 2-week hospitalization with a 6 or 8 week convalescence. The changes are tremendous. The way we handle breast cancer, breast preservation, breast conservation. There's so many advances that the appropriate use of transplants for certain hematological malignancies, the cures that we can now achieve even with chemotherapy and lymphomas. There's been a dramatic change in how we practice medicine in my tenure as a physician.
So could you classify a single most important breakthrough in technology in those radiological?
Well, each one builds upon the next.
Right.
And so with the ability of CAT scanning, and now the MRI, and now second and third generation CAT scans that now allow visualization of blood vessels, the advances are tremendous. How we treat coronary artery disease. When I first went into practice, if you had a coronary, you were kept in bed for 6 weeks. People are now out in 5 days. The ability to open up blood vessels, the introduction of a lot of effective preventive health measures for coronary artery disease, the realization of the need to control blood pressure and avoid smoking and exercise, that has led to tremendous improvement in how we treat disease, and has led to tremendous expansion in the longevity of people. I mean, we're dealing with an aging population because medicine has improved so much that we're able to keep people alive for an additional decade or two than we formerly were able to do. I mean, and that creates a whole series of other social economic problems, the long-term care, and how we deal with our aging parents, and who's going to take care of them, and the cost of drugs to keep these people going. So there's it's like a building block as you lay the foundation for some improvement. It spawns all kinds of byproducts, achievements as well as problems.
what illness was the most challenging for you to treat when you practiced?
Acute leukemia. The most devastating, the illness that required the most supervision, the unpredictability, the poor prognosis, and especially when this affected young people, not being able to do very much for them initially, and to see the progress that we made in this disease over the years. It's been very a delight, where we can cure probably 80 or 85% of children with acute leukemia. We can cure maybe 20 or 25% of adults with acute leukemia. When I first went into practice, the average survival of an adult with acute leukemia was 3 months from the diagnosis. So that's been the disease that I dreaded the most, because of the complexity and the severity of the illness and the bleeding and the infections and the complications, but I've seen tremendous improvement and changes in that.
So you classify that as the worst epidemic you ever saw?
Well, it wasn't an epidemic,
Oh, right.
you know, but in terms of an illness, it was probably the most devastating illness for someone to have to, in my field, in the field of hematology, oncology.
Can you recall any devastating epidemics during your career?
Devastating epidemics, I would have to say I can't recall any. I know of them. I mean, there were polio epidemics in the 50s, but that was really before I got the last of the polio epidemics. I mean, again, to see the eradication of smallpox and essentially the eradication of polio, you know, during my lifetime is certainly a major accomplishment. Epidemics, I think the epidemic that probably was the most challenging is the HIV epidemic in my practice career, and in terms of not being able to cure the patient and the long-term complications and the impact it has on the individual and on the families and on society.
Could you briefly describe attitudes towards smoking and cancer throughout your career?
Well, I can remember going to medical meetings 35 or 40 years ago, when you would probably see a fair number of the physicians at the meeting smoking, maybe even half. And you see doctors who would be making rounds, you know, smoking, I think even in the hospital setting. And people smoked in the hospital. You go to a medical meeting now, there can be 300 physicians, and you don't find one of them smoking. I mean, so we do practice what we preach. We do know the dangers of smoking. And as an oncologist, I mean, I'm always been a advocate of the folly of smoking and the realization that probably 25% of all malignancies are in some way connected to smoking. It's led me to be, I guess, a major irritant to anybody I see smoking. But it's certainly, there's been a tremendous change in the physician pattern of smoking. You very seldom see us. You very seldom see anybody that is health conscious in this day and age that smokes.
What is something that doctors take for granted now that you didn't have at some point in your career, in terms of technology?
Well, we had, compared to what we have now, we certainly did not have any of the sophistication, radiological sophistication, intensive care sophistication, laboratory testing that is now available. When I first went into practice, many people didn't have health insurance, and physicians did a lot of work for free or for charity. The city hospitals all were flourishing because that's where people went when they didn't have health insurance, and somebody had to take care of them. They were great centers for teaching and for providing health care to the poor and people who are uninsured. And then the ability of most working Americans to have their health care covered was a tremendous advance that opened up a lot of health care services to people who were formerly denied them. And was, as a corollary, was a bonanza for physicians who practiced, because now that patients who they formerly treated for free now we're able to pay for their health care. So that was considered by some to be a golden age of medicine, with the introduction of Medicare by Lyndon Johnson in the late 60s.
Well, I'll get back to Medicare and managed care in a few minutes, but before that, could you tell me if you had access to new technology all the time?
I would say yes. Worcester is a wonderful medical center, and the hospitals and their staffs were very good. Good doctors demand good facilities and good support systems, and by and large, the hospitals in Worcester were able to provide state-of-the-art, good medical care. I never felt that patients were deprived by having their health care services here in Worcester and at the hospital I worked at, St. Vincent's.
Is there anything that you would like to see invented in technology or anything in your field?
Well, I think as we begin to understand genetics and the genes, and we begin to identify which gene defect causes a particular disease, we will go from as we gather more understanding, the opportunity to correct genetic problems, such as hemophilia, which is a genetic problem, such as diabetes, probably has genetic origins. The promise of what lies ahead is just tremendous in terms of how we will be able to tailor therapy for specific diseases based on the genetic analysis and what the abnormal protein is, and be able to correct it in some fashion. It's very exciting, the thought that this will happen. The ability to alter the course of cancer, to correct some of the defects that allow cancers to develop, whether they be abnormal suppressor genes, or it's so exciting.
Could you name some of the most important drugs that you used in your practice?
Well, chemotherapy in terms of the whole different generation of drugs that have been developed, that have been introduced to clinical practice. As I said, the two drugs that I find very fascinating are drugs that are specifically tailored at either a abnormal signal, such as in chronic myelogenous leukemia, which causes the chromosomal abnormality causes an abnormal protein to be made, which is a tyrosine kinase, and the ability to develop a drug that inhibits that and causes 95% of patients now to go into complete hematological remission and correction of the abnormal chromosome in maybe a third of those patients. That's extremely exciting. The same thing with breast cancer. The ability to identify a growth factor that in certain breast cancers that we can now treat with an inhibitor to that growth factor, Herceptin. That's another example of moving the technology into a more advanced state of art, as opposed to using poisons. That's how we've typically treated cancer, using alkylating agents, which are cellular poisons. So I think that this is the direction where oncology is heading, and it's very exciting.
Did you always have access to the drug that you wanted to use?
Yes. If they were experimental, I could get them through the National Cancer Institute as an investigator. So that was not a problem.
So how did patients with that money get health care? Did they just receive it no matter what?
Well, in the era where city hospitals were flourishing, if you didn't have health insurance, You showed up at a city hospital. You went to, they had clinics, they had emergency rooms. Perhaps they may not have had the continuity of care, but they had very active clinics where you could be followed by young physicians who were oftentimes very caring and enthusiastic and committed. So people were able to get health care.
Over the years, how do you think Worcester compares to other places in terms of providing care for the underserved?
I would have to say it probably was as good as, I think Massachusetts in general, we had a very liberal social health care system. People who were poor were put into Medicaid, where the state was provided health care services. We now have a health care crisis in this country now in terms of the numbers of uninsured that are increasing. The reimbursement rates don't cover the costs for some of the programs, the Medicaid, Medicare. The budget's just been passed is going to eliminate 50,000 people from the Medicaid rolls. Today, two other drug chains have said they won't accept the Medicaid reimbursement that the state is going to offer them. So we do have a health care crisis in this country. It's somebody who's always been interested in health care. I think it's inconceivable that we don't have universal health care in this country. I think everybody should have a basic package of health care services that is available to them, regardless of whether what their income is or whether they're working or not. We should have a universal health care system. We spend enough money that we should be able to provide that. However, it's a societal issue because we probably can't do all things for everyone all the time. And there has to be some limits. And America and Americans in general are not willing, those who have don't want to give up anything to those who don't have anything. And that's what we really need. We have to have a rational healthcare system that ensures everybody has a basic level of health care, but we can't provide every conceivable service to everyone all the time. There have to be limits, and that's where we get into conflict about who the wise people are who are going to decide who gets when, and how, and where.
So what were some fears and concerns about socialized medicine in the 50s and 60s, or when you first started practicing medicine?
Well, there's always been a concern that the government is going to take over health care, and that was always a major concern. Well, the government is a major player in health care. The government provides Medicare, to seniors, and probably 2/3 or 60 or 70% of all hospitals care is provided to that population. The government's already the payer in that population. I think that the government plays a role as a major payer in health care. The government is concerned because senior citizens are concerned about the high cost of drugs, who's going to ensure that they have access to drugs, so that there is a role for government, but we certainly do not want the government to decide. The government can be the payer, but in terms of quality of care and the control of the healthcare system, the government has to be a watchdog, but they shouldn't dictate the terms. And that's a very delicate balance, because he who pays the bill wants to control the system. And the physicians have typically been in a role of being the advocates for their patients. But again, there's a balance between advocating for the social good and advocating for your individual patient. Physicians are very comfortable in advocating for the individual health care of their patient. They feel very more reluctant to be part of a system of health care that may limit what is in the best interest of a particular patient in terms of a social good. And that's the conflict that you have, the individual and their needs versus society and their needs. And is it better to spend $1 to provide immunization for children, or is it better to spend $1 keeping an 85-year-old person on dialysis? And those are the the conflicts and the tugs that go on. And when you make that into a global conflict, not just on an individual patient, but when you're talking about populations, you get into major philosophical differences about what the healthcare system should be like. I'm all for a healthcare system that ensures everyone has some healthcare, a basic level of healthcare that provides preventive healthcare services, that provides immunizations, that provides nutrition, provides adequate obstetrical care. I'm not so concerned that the healthcare system pay for botulism, Botox injections for eliminating wrinkles or that type of thing.
So were physicians ever involved politically on the topic of socialized medicine?
Oh, sure. The AMA, you know, the professional organization that represents physicians or represents a fair number of physicians has always been advocating against programs like Medicare, socialized medicine, government involvement. We even have a physician who's a senator, you know, Bill Frist from Tennessee. So the physicians have been active. The governor of Vermont, Governor Dean, no relative of mine, is a physician.
How were you personally affected when Medicare and Medicaid came around with managed care?
Well, I've been a leader in my organization in terms of managed care. I was very active in the Fallon Community Health Plan. And I think managed care is not a bad way to organize a healthcare system. I think there are a lot of good things that managed care has accomplished in terms of its emphasis on preventive health care and providing access to health care. I think the problems with managed care has been where you have non-physicians perhaps deciding what was appropriate and what was inappropriate, and I think that's not. That particular type of control or regulation was never really part of the healthcare system that I was involved with. That we were a physician-directed organization. And we set up our own healthcare system called the Fallon Community Health Plan. And even though there were times when there might have been some conflict between an individual physician and what he wanted for his patient, I think that the people making the decisions, the majority or most of the time, were physicians. And whether there were guidelines that we set up or these were all done with the participation of the physicians who were experts in the field. So that I think that my experience with managed care has always been very good. But this is not the experience of a lot of physicians.
When did HMOs first start to impact your practice?
Well, probably in the early 70s when we set up, again, my experience at the Fallon Clinic, when we set up the Fallon Community Health Plan, by and large, our practice was all fee-for-service. And when the health plan started around 1979 and 1980, quickly it was such a success that within several years, 80% of the practice were people who had enrolled in the managed care. And it grew to be very successful because it was good. It was able to control healthcare costs to some extent. It was able to provide very good health care that the patients were satisfied, and they spread the word to their friends and neighbors, and we grew tremendously, and it was very successful. And we were rated a top HMO. We very early on had very high rates of preventive health care measures. Our immunization rates in pediatrics were the highest in the country. Our mammography rates were the highest in the country. And we practiced a very good brand of medicine.
Did you ever see any negative aspects to HMOs?
Well, sure. Most physicians like to make decisions, and Again, the emphasis in medicine has always been to try to do the most you can for your patient, and that meant sometimes doing things that were not medically indicated. One thing that managed care has done is to look at the way we practice medicine and to try to introduce what's called best practices, or to establish guidelines to help physicians do what's right in a timely fashion for patient care. So my experience, by and large, was positive about what managed care was able to accomplish. However, there again was a backlash against managed care, because again patients wanted to not be denied anything that they thought they were entitled to. If a patient thought they needed a CAT scan, and the physician knew they didn't need a CAT scan, and the health plan knew that there wasn't an indication for the health plan, you're building a scenario where people are going to be upset. And that's part of the American way, is we want everything done, or some of us want everything done when we want it, and we don't like to be told that it's not indicated.
Okay. Well, moving on from managed care now. How much
I always thought managed care, all care is managed. Even without managed care, I mean, I don't like the term. I don't like the term managed care, you know, because all care is coordinated, and managed care is a system to try to coordinate the care, where you have people that have studied what's called best practices. What's the best way to follow a patient with a diabetic? And once you've identified what these things are, to try to introduce them into the practice of medicine, so that the quality of healthcare is improved. So to me, I don't like to be managed. I don't think any of us like to be managed, and the term itself is offensive. But I think it's a system of coordinated care, when, if it's done right, is an excellent way to organize your healthcare system. But it has to be done right, and the physician has to be the major player in determining what's right, because he's the experienced person. You know, he's the quarterback and the captain of the healthcare team. He knows probably the best, but he's not the only person. You can be the best quarterback, and you need 10 other people on the team, to be successful. And the same thing with healthcare. There are other people that have knowledge that have to be incorporated into developing and devising and coming up with a good healthcare system.
How much did it cost for you to go to medical school?
You know, I really don't know. I graduated with medical school not owing a penny. My parents were hard-working people. They helped. Yeah. I worked throughout medical school. My 3rd and 4th years, I worked at hospitals as what was called an extern, where I did histories and physicals. I got room and board. And so I know it's a huge expense these days. The medical school graduates are coming out with bills of debt of approaching or exceeding $100,000. It was not my experience. I worked and offset a lot of the expenses, and tuition wasn't as prohibitive as it is right now.
So do you think med school tuitions affect the choices of young doctors after they graduate?
I'm sure they do. I'm sure it motivates them in terms of, along with housing costs and how much debt they owe, it forces them to make decisions about where they will live and where they will practice, and where the best opportunities are for them in order to pay off their debt. So sure it does. Economics determine a lot of things. That's what Karl Marx said. You know, and it's true.
Were any doctors when you went to medical school affected by med school tuitions like doctors are today?
Oh, I think they came out with, some of my classmates came out with debt, but certainly not approaching the magnitude currently. And I'm sure it does affect perhaps the specialties you go into. It probably affects where you're going to, locate in terms of what region of the country. I'm sure it has a profound effect. If you have a debt, a medical school debt of $100,000, and the price of housing in Massachusetts, especially in the Boston area, is so costly, it's going to be very difficult if you really wanted to practice in the Boston area to take a job there, as opposed to maybe taking a job in Wisconsin or in North Carolina or Oregon.
How have doctors' salaries changed over the course of your practice?
Well, I think probably if you talk to doctors, most of us would probably say we're overworked and underpaid, but I suspect that's not an uncommon feeling in a lot of professions, that we feel we're undervalued. I always worked in a group practice. I was always paid a salary. I think my salary was fair. I didn't go into medicine to become wealthy. I knew I'd make a good living. I'd always be able to provide for my family, and that was not a predominantly motivating factor. I think that there's been some effort to balance the earning capacity of the so-called high earners who are in the surgical specialties versus the primary care type physicians who do more hands-on, cognitive type of thing. And I think that's a good thing, where the top earners are maybe earning less and the lower earners are earning more. I think there should be more of a balance, and I think that's a good thing. But I would imagine those people who practice the specialties where they see their earnings eroded don't feel that way.
Where was most of your income from in the early part of your career?
I worked in a group practice, and I worked on a salary basis.
Yeah, okay.
And if the group did well and we individually contributed that, there was always an opportunity to share in the success of the group. And I think I was treated fairly by and large.
How has malpractice insurance changed over the years?
Well, it's a major factor. When people talk about the exploding cost of health care, it's due to multiple factors, including the high cost of drugs, the new technology that we've introduced, the aging population that requires increasing health care services, the expense of drugs I mentioned. But malpractice is certainly a major factor. In some parts of the country, an obstetrician has to pay over $100,000 in malpractice insurance. And that's and there are certain areas of the country where orthopedists and anesthesiologists just are leaving those states because they can't afford to pay the premiums, and I think that's a societal issue. I think there has to be some limits to the so-called pain and suffering in the jury awards. In Massachusetts, most of the malpractice cases are decided in favor of the physicians. I'm not aware of the latest statistics, but about 85% of the time the malpractice cases go in favor of the physician and against the plaintiff. But I think there has to be some federal relief. There has to be some way of limiting these huge malpractice awards. Medicine is both a science and an art, and no matter how good you are, things are not always going to be. You can't expect 100% success. You're delivering babies. You have difficult pregnancies. Some women are not getting, may show up for their maternity care late in their pregnancy. Things are going to happen that don't always represent malpractice, but represent a bad outcome. And just because there's a bad outcome, whether it be related to a auto accident or a pregnancy, doesn't mean somebody should be sued because they're not happy with the outcome. And I think the malpractice awards and the situation in this country is unique compared to other places like Japan or even in Western Europe, where they don't have to face a society that says if something goes wrong, we're gonna sue the pants off of you.
So this is a topic that you rarely had to think about when you started practicing in the 60s and 70s.
Well, malpractice, it's probably luck, but I was never involved in a malpractice case. I was never sued by anybody. And again, I think it's luck, because it doesn't necessarily mean I was better than other physicians in my field. A lot has to do with personality. As a physician, you can't be arrogant. You have to be nice to your patients. You have to be available to your patients. You have to be in a position where you explain things to your patients, and you have to be honest and open with your patients. And if you do those things, and you try to do a good job, I think you're going to escape most of the malpractice problems. But again, there's a luck factor too. There are some people who are just going to sue you because the outcome is bad, even though you may have done the best job possible.
Could you just quickly tell me what the typical fee for an office visit was when you practiced?
When I started, it was probably about $12 or $15. It's probably now for a regular routine follow-up office visit. I bet you it's in the $75 or more range. You know.
It's probably a lot to do with inflation, though.
Yeah, it has to do with inflation. Yeah, I remember when a cantaloupe was 20 cents too.
How did you end up learning the business of medicine?
Well, again, I learned the business of medicine. One of the nice things about a group practice was that we were somewhat sheltered from the business aspects of, you know, we had people who were involved in managing the business, administrative type people, and we were really, I never in my entire practice ever took money from a patient. Whether I made a house call or saw them in the emergency room, I would always, you know, generate a bill through the business office. But I was involved very actively in the Fallon Clinic as an administrator as well, and I served on the board of the Fallon Clinic for over 25 years, and I was the president of the Fallon Community Health Plan, and so I was very heavily involved in a lot of the business aspects of somebody has to do it. And serving on as a member of the board of directors, you review budgets. I was a division director of hematology oncology. I was responsible for a budget, so you learn what you need to know in order to handle the responsibilities that you assume.
What are some changes that you've seen in the demographics of the Worcester community?
Well, I think we have more minorities. We have an inflow of people from more Latin Americans, Latinos, people from Cambodia, from Southeast Asia. The demographics have definitely changed from when I first went into practice, reflecting you know, the immigration patterns in this country. We have a lot of people coming from Brazil. America is a land of opportunity. So many people want to come here, and each wave of immigrants have contributed to the success of America. And
did the ethnic background of your patients change proportionally with that?
Yes, and as these populations came into our community, we began to see them and care for them, and we developed translator services so that we could properly obtain histories from them and help us with the practice of medicine. So the hospitals have signage in several languages. There are interpreters available to help with people who don't have English as their first language.
How did women's health in Worcester change over the course of your practice?
Well, I think there's, in general, a much greater awareness. It became sort of almost a specialty, women's health care, where before health care you had men and you had women, and there was a feeling that women's health needs needed to be, in some sense, separate and dealt with by people that specialized in women's health care issues. Women have become an extremely important part of the healthcare system. When I started out in medicine in my graduating class at Tufts, out of a class of 100, there were 3 women as physicians. Now probably at least half, if not more, of the medical school classes are composed of women. So that with the women entering into medicine, women who might have forced to use a man as their physician now found that they could have a choice of a woman, felt more comfortable, felt that there was somebody who could relate to them in a more effective fashion, who had a greater understanding of their particular healthcare needs, and I think that's where this emphasis has sort of naturally evolved, and it's a good thing. I always felt very comfortable treating women. I don't know if the women patients felt as comfortable having a male as a physician.
Have there been changes in how children are cared for at all?
Like everything, the pediatric practice has changed tremendously, with nurse practitioners, a much greater role for a whole series of immunizations. New vaccines have appeared. The specialty itself has matured. Adolescent medicine has become separated a little bit from pediatric medicine. The role of nutrition, the role of obesity and starting in childhood, the specialization among pediatricians, so that like every field in medicine, there's been a growth in knowledge and an evolution and how it affects the practice of that specialty.
How do you feel the role of the physician in the Worcester community has changed, if it has changed at all?
Well, the Worcester community has changed dramatically. Everything has changed. The only thing that's certain is change, and we've gone from 6 hospitals to 2 hospital systems. We have large healthcare systems. We have managed care. Technology has changed. Physicians who used to practice medicine and go into the hospital, we now have hospital care being provided by intensivists. Many primary care physicians have very little or no involvement in the practice or care of patients in the hospital. The role of the intensivist, the diagnostic, therapeutic, the changes and evolution of healthcare is dramatic and tremendous. I think if a physician Rip Van Winkle, who awoke 30 years and went in to see, followed one of his colleagues in his office, or made hospital rounds, would be out of his league. He wouldn't understand what has happened. And I would say 30 years from now, the same will be true. Maybe even more dramatic.
Were there Worcester physicians that you admired when you started practicing?
Definitely. The doctors here at the Fallon Clinic were role models and were great teachers. I learned a lot of medicine from my colleagues here at the Fallon Clinic, and I learned a lot about the dignity of medicine and the honor of medicine from my colleagues.
Well, obviously, Dr. Dean, medicine is a changing and growing field and will always remain to be so. And so that leaves a lot to be learned by doctors, obviously, like every year as as they progress in their practice. How have you personally kept up with the changes in medicine and in medical education over the years after med school?
I'm glad I'm not trying to have to go through medical school now. I mean, they say knowledge doubles every decade, probably even faster now. Uh, Personally, I still go to a couple conferences every week, and I continue to read several medical journals religiously. I'm a student, and I've never ceased being a student, and I hope to be a student even though I may not practice. I hope to continue to be a medical student all my life. I also go to a couple national meetings every year as well.
Is there any other story or any other experience throughout your life pertaining to medicine that you'd like to share before we wrap up here?
Well, just that I think that my own healthcare experience sort of made me a better physician. When I was 43, I had colon cancer. And even though I was an oncologist, being on the other side of the bed, so to speak, being a patient instead of the physician, it was a real eye-opener. It was a real humbling experience. And I think it made me a better physician, and it made me much more empathetic than I had ever been before. I could really, I think, understand and appreciate what it was like to be a patient and to be ill and to be facing the uncertainty of a healthcare situation.
Okay, and lastly, what advice do you have for younger doctors?
Well, the only advice is that I think they've chosen a wonderful profession, and that each generation has to define its own relationship to their career. One of my colleagues, Leonard Moss, always talks about medicine as a noble profession, and it is. And I think it's a great profession, and I would encourage them not to be in any way be disenchanted.
Okay, thank you very much, Dr. Dean.
Okay, my pleasure.